Dr. Schulman is a professor of medicine and professor of operations, information, and technology at Stanford's Graduate School of Business. He serves as interim division co-chief for the Division of Hospital Medicine at Stanford and as an associate chair of the Department of Medicine. Dr. Schulman is a health economist and health services researcher working at the intersection of business, medicine, and technology. His research has appeared in the New England Journal of Medicine, the Journal of American Medical Association, and Health Affairs. So Dr. Schulman, thanks so much for joining us today, and I'm excited to talk about your new article. And then also, I can just go ahead and introduce Dr. Archbold. He's an attending anesthesiologist at Elmhurst Hospital in Queens, New York City, and is on the Doctors Council of Service Employees International Union. He's a member, and that's I had to look it up just to confirm, but it's the largest union of attending physicians in the country, which is really cool. He did his residency training in Ireland and completed a fellowship in regional anesthesiology and acute pain management at the Hospital for Special Surgery in New York. And then he's also worked as an MSF doctor in Gaza in 2018 and 2019, and is an active MSF USA Association member. And then finally, to round it out, okay, so Dr. Sanjeev is an adult medicine hospitalist employed by Delaware's sort of largest medical system, Christiana Care. He's a leader in the physician unionization effort. He went to medical school at Madras Medical College in India and completed his internal medicine residency at Rochester General Hospital. He's board certified in internal medicine. So thank you, everyone, for joining us. Dr. Gandhi, if you'd like to say a few words about yourself.
Yeah, I think I was delinquent and didn't send my CV on, but I'm happy to just introduce myself. I am Nisha Gandhi. I am an advanced heart failure and transplant cardiologist. I work with Dr. Sanjeev at Christiana and also help to organize our new union, which we're very excited about. I did all of my training at Thomas Jefferson in Philadelphia, with the exception of my heart failure and transplant cardiology fellowship, which I did out at University of Washington in Seattle. I think that was everything. And I'm so excited to be here with all of these bright faces. Thank you for inviting me.
Perfect. Well, thank you to our speakers, and Dr. Schulman, I'll let you kind of take it away.
Great. Well, thanks again for inviting me. So let me, so I get to kick this off and talk about kind of, I've titled this Physician Government in a Consolidated Healthcare Market. And, I think the important thing to realize, and we'll go through this, is there are lots of changes that are happening concurrently in the healthcare market. And this effort to unionize we see this as a response to a lot of these changes. So, so let me just start here and thank my co-authors on this work, Brock Richmond, Dan Bowling, and Hayden Rook-Lee. You'll see there's a lot of JDs after these folks' names, but Brock's a health lawyer, Dan's a specialist in labor law, and Hayden actually is a clerk in federal district court, was a Stanford law student. So, I think we see these headlines all the time of different hospital systems merging, one hospital system acquiring another. And, for most of the last decade, this has really been the story. So here's Advocate Aurora merging, here's Intermountain Healthcare in Utah, and then Sutter Health out here in California. And so this idea that hospitals are buying other hospitals has become really routine. But I want to take us back a little bit and say that that was not always the case. And here on the left is a young Bill Clinton who entered the presidency, 30 years ago. And one of the things that Clinton wanted to talk about was healthcare reform. Kind of the idea of healthcare reform in 1992 grew out of a special election in Pennsylvania in 1991, where a no-name person, Harris Welford, won a Senate seat by talking about healthcare. And so since that happened, healthcare got elevated in the national discussion. Now, Bill Clinton didn't have a lot of ideas about what healthcare reform he wanted, On the right is a picture of Alan Enthoven, who actually I'm supposed to have lunch with sometime soon. He's in his mid-90s now, but he was a health economist here at Stanford at the business school. And Alan came up with an idea called managed competition. And what he did was look at Kaiser Permanente Health Plan here in California and how successful they were at negotiating between doctors, hospitals, and within the constraint of a premium payment, and said, we have an issue with cost of healthcare in the United States. If we had more of this managed competition where where doctors and health plans work together to keep people out of hospitals, we could reduce the cost of healthcare. So for Alan and what was Clinton healthcare reform, the model was doctors and insurance companies working together and keeping patients out of hospitals. And by keeping people out of hospitals, we reduce the cost of healthcare. And so that was the rhetoric from the mid-1990s. So obviously, Clinton healthcare reform didn't go anywhere, lots of reasons for that. But this rhetoric that hospitals were vulnerable to doctors working with insurance companies really stuck home. And so there was a really significant response. And that response was the development of these healthcare systems. So, as you look around the market, so Sutter Healthcare here in California was created in 1996. Partners Healthcare was created in 1994. Duke bought its other regional hospitals in 1997, Centera in 1995, Ascension Healthcare in 1999. And at one point, actually, UCSF and Stanford actually agreed to merge before that thing whole blew apart. But what you see is kind of this direct response, and the timing is really interesting. It's all in the wake of these national discussions led by President Clinton about the structure of the healthcare system. And so hospitals responded very aggressively over time. And so as we go forward to 2010, and healthcare reform again becomes a topic of discussion, national policy discussion under President Obama. And the rhetoric of healthcare reform from 1993 to 2009 was the same. It was hospitals were expensive and doctors and health plans had to work together to keep people out of hospitals. We're hosted today by Dartmouth, but one of the Dartmouth faculty members is a guy named Elliot Fisher. And Elliot had a different idea. And Elliot's idea was, if we could get doctors and hospitals to come together to provide quality healthcare, we could reduce the cost of healthcare. And so the rhetoric really switched. Elliot was very successful in getting this ACO concept in front of healthcare reform with Don Berwick and Mark McClellan and others. And this idea was, doctors and hospitals are going to work together to reduce the cost of healthcare. Now, Elliot's ideas flew in the face of 20 years now of experience out in the healthcare market where hospitals had consolidated to drive up healthcare prices. There was no evidence that doctors and hospitals had ever worked together to reduce the cost of healthcare. But Elliot was, like I said, really effective and got his idea of ACOs into what became Obamacare. That was not, so as the Obama administration came in, the idea that hospitals and doctors were working together was a good thing, right? Because we had this Elliot's idea of accountable care organizations. So we started seeing federal health policy that really, benefited or moved physicians to think about working with the hospitals more closely. And one area that really benefited hospital-based practice over independent community-based practice was what was called site of care payments. And so in the old days, if you owned your practice, you billed for your physician professional time and your practice expenses. But when the hospital acquired your practice, you became facility-based provider. And so you billed for your professional time, but the hospital got to bill for the facilities, the echocardiogram, the MRI machine, and the drugs. And the federal government, again, doctors working in the hospitals is a good thing. So the federal government ended up being very generous in terms of payment policies for hospital-based practice. And so here is some ideas about this is 1 year savings from site neutral payments for a hospital outpatient practice. But what this is an assessment of overpayments to hospitals for physicians working in hospital outpatient departments. And these are total underestimates. And so we started paying hospitals more to provide clinical services than we were paying docs in practice. And you've never heard of something called 340B. But as we look around the country, this is the #1 profit center for 340 for participating providers. 340B is a program that dates back to 1992. In 1990, the federal government passed a law that required Medicaid plans in the United States to get the best prices on medications in the market. And it turned out at that time, there were a really small number of safety net providers where the pharmaceutical industry sold drugs to the providers at really steep discounts. And all of a sudden, those safety net hospitals like Cook County Hospital in Chicago couldn't get their medications at these discounted prices. And they went back to Congress and said, yes, you're trying to support the Medicaid programs, but you're hurting us as safety net providers. And so Congress passed a law, this 340B law, that basically exempted hospitals that were designated as 340B from Medicare best price determination. I'm sorry, Medicaid best price determination. And so if you're a 340B hospital, actually by law, a pharmaceutical company has to sell you their drugs at a really steep discount. It's the amount of the discount secret, but it's 25 to 50% off the list price, somewhere in there. In 1992, medications weren't all that expensive, but that's no longer true. And so this is actually another paper we published recently. And so in 2022, hospital outpatient departments were able to buy $110 billion worth of drugs for $50 billion. And under 340B, because the program was originally designed for safety net hospitals, there's no restrictions on what you can do with those drugs. This paper is about the markup to Medicare, about how much you make off Medicare prices. But if you sold these 340B acquired drugs to private commercial health plans, you're probably getting 3 to 5 times or more the wholesale acquisition cost. And so this is hundreds of billions of dollars that are going into hospital outpatient practice that are not available to freestanding oncology practices. And again, this is expansion of 340B was part of this idea of doctors and hospitals working together to reduce the cost of healthcare. And then finally, antitrust enforcement. So, the idea, again, of ACOs was, well, we shouldn't be concerned about some of this hospital consolidation, and we shouldn't be concerned about some of this consolidation of doctors and hospitals, because that's all in the mission of these ACOs that are going to reduce the cost of healthcare. So we have this guidance from the Justice Department on antitrust policy. At the time, we said, be careful of this idea of ACOs. And that this, the rhetoric, there's almost no evidence that doctors and hospitals working together will reduce the cost of care, especially for Medicare. But actually, there is evidence that hospitals consolidation has been having a negative impact on the cost of healthcare in the private market. And so, we raise concerns that these things, ACO arrangements could actually exacerbate hospital monopoly pricing going forward. But nobody listened to us in 2011. So what happened over the last decade is really amazing. We went from about 5.6% of docs being directly employed by hospitals in 2012 to roughly 52% of docs being employed by hospitals in 2021. And then, as you see on the right here, on top of that, another 20% of the physician workforce is employed by other types of corporate entities. So Optum Healthcare you might have heard about, but private equity-backed practices are about 20% of all physician employment. And in fact, the scale of this is enormous. In 1 year after the pandemic, 100,000 doctors changed their practice from freestanding practice to either hospital-based or employed by a group practice. So this is a massive shift that's occurred over a decade. And I should say, the shift is doctors being employed by hospitals, and we should use that wording. Doctors and hospitals have worked together in the past, and there were lots of different governance models of that. In the 1990s, we called it physician hospital organizations. There were associations of partnerships between docs and hospitals, but we've never had a pure physician employment model, definitely not at this scale. One of the things I look at a lot is Kaiser. Remember, Alan Enthoven's model originally was based on Kaiser Health Plan. And we all talk about Kaiser as if it's one entity, but it's not. Kaiser actually has 3 different entities that come together. The permanent day medical groups, which actually are for-profit group practices, physician group practices. The Kaiser Family Foundation hospitals, which are not-for-profit hospitals organized by Kaiser. And then the health plan itself, which is also not-for-profit. And the interesting thing in the Kaiser model is the hospitals are not profit centered, they're cost centers. The doctors and the hospitals and the health plan all get together once a year to arm wrestle and negotiate over how to divide up the premium budget. But the hospitals are seen as not as a profit center, as a cost center. And that's a dramatic difference from how everybody else is organized in the healthcare market. I found this in modern healthcare, which is really amazing. So again, all this consolidation occurring. This is a paper from 2018, and this is health system governance structures and their recommendations for the different optimal models of the governance of healthcare systems. And just take a look at each of these 3 models and tell me. Actually, you guys raise your, or put in the chat what you guys see. These are healthcare systems. And again, these are employing physicians. And this is the recommendation of the Modern Healthcare Consulting Group about the optimal way of organizing healthcare systems. Anyone? Oh, great, we got it. The bottom one looks complicated. They all look complicated. What's missing? Oops. I'm gonna just for interest of time, where is the role of doctors? We're the ones providing healthcare. The hospital administrator is in charge of making sure that their bedpans are changed. And in this idea of optimal structures of healthcare delivery systems, there is no governance role for physicians, even though 52% of us are employed by these entities. That's not just an oversight. That's how hospital administrators have been trained. This is what their job is. And so now we have employed physicians employed by hospitals, and that we're teaching the hospital administrators this is how you run your healthcare system. And obviously the result is this idea of burnout that people have been talking about. as a physician that's now employed by one of these structures, it's hard to understand what they're trying to optimize. Our role as leaders of the healthcare system is potentially compromised in lots of these programs. I talked to one of my former students who's an orthopedic surgeon in North Carolina, and somebody somewhere, his hospital is part of Atrium, which got merged with somebody, and they decided to standardize their Epic. And in doing so, they wiped out all of his smart notes. So he had spent like 5-6 years building work processes for his practice, and some MHA graduates somewhere very down low on the food chain just decided to wipe that all out. And so that's a role that we're not used to as providers. I would also say that there's lots of evidence that these healthcare systems are not benign, not just to us as physicians working in these entities, but here's some New York Times headlines about how these systems have been operating in the public sphere. Out here, Providence Healthcare System, a Catholic healthcare system out in Washington State, hounding people that were entitled to free care under state law. The Bon Secours in Virginia, this idea that they were buying inner city hospitals and using them as 340B providers to establish clinics in the suburbs so that they could get access to the 340B markups on oncology drugs. And then Allina Healthcare System, how they cut off patients with medical debt. So the real questions about what healthcare systems, how they're being run and how they're being optimized. And then in terms of costs, we've gone, costs in the United States kind of has risen as a result of these strategies. We went from 13% of median family household income in 2000 as the cost of employer and employee provided health insurance to 25% of median family household income in 2021, doubling of the cost of healthcare in the United States. And as you know, and you probably had talks on this, that's not been associated with dramatic changes in health outcomes. If anything, health outcomes in the United States, we know health outcomes in the United States lag far behind every other country in the world, even though we're spending at least 5 or 6% of GDP more than other countries. So we, with Barack and Dan, we kind of asked the question, like, what can doctors do? How do doctors respond to this now that they find themselves as employees of hospitals rather than partners with hospitals? And as employees, when you owned your own practice, you couldn't join a union, but now that you're an employee, you can. And so we went back and looked at this idea of what are physician unions, what are the legal ramifications of establishing a union, joining a union. And it's interesting and tricky because unions were built by FDR a century ago, thinking about people on the assembly line floor of a car manufacturer. And now we're asking the question, well, can physicians join unions? And if we did join a union, could that address some of the governance challenges that we're all facing? So Labor Law 101, this is Dan's piece of this. The first is a union is just a mechanism for collective bargaining rather than individual employment negotiation with employers. So I'm now in management, actually, since we wrote all this stuff. But so I'm the co-chief of hospital medicine. We have 80 docs in our division. Each one of them negotiates. Actually, we have a fee schedule, so it doesn't make a difference to negotiate. But in principle, each one of them negotiates with us individually, but they could negotiate collectively as a group over their employment contracts. So unions an organization elected by a group of employees to bargain with its employer over wages, hours, and other terms and conditions of employment. And this, again, wages and hours goes back to the 1930s. Terms and conditions of employment become really important today when you think about what can a physician union do for us in terms of governance. Employers are required to bargain in good faith with the union. a union, but they're not required to agree with union demands. So just because we decide to form a union doesn't mean that we can actually come to an agreement with an employer. And then contracts are binding on all parties for the contract period. And one of the things that, people are very concerned about physician unions with ideas like strikes. And one of the things that the union labor leaders say is actually union contracts are the way to prevent strikes. Union contracts actually prohibit strikes for the duration of the contract. And so, at some level, this is a way for us to harmonize around labor issues rather than make them more contentious. So physician compensation and practice acquisition. So physicians sold their practices into these either to the hospital or to a private equity group. And what you see is the terms of these sales are pretty generous. Like, we want you to join our hospital, we want you to join our group practice, and we'll give you like a 2 or 3 year contract. And then when the contract is up as renewal, then they got you. You have no leverage at that point. You've already sold your practice. You're negotiating as an individual. And so this conclusion, that physicians as a whole might capture much, might not capture much of the increase in system profits that occur after vertical integration. And so we're being really challenged by these models. I used to be at Duke, and I would explain to people, doctors at Duke, their variable costs and their fixed costs to the Duke Health System. The buildings are fixed costs, and all the physicians that I was talking to in the audience, they were variable costs. And if the hospital had to make budget, they were going to come back in terms of not increasing wages or cutting staff. There is some evidence that unions actually help workers in terms of negotiating with employers. And this is actually a really interesting paper about compensation in Michigan in the auto workers industry, where productivity was going way up, and then workers' compensation was not benefiting from that because of the the weakening of labor unions in the state. So, weaker income inequality, the authors suggest, reflects a greater erosion of collective bargaining there in Michigan over that time period than in the country as a whole. So going back to the law, so there's this idea of mandatory bargaining, where management must bargain over provisions of labor agreements. There are ideas of things that can be bargained with the consent of management. Management can rather than must bargain over these provisions. And then there's the idea of management's decisions and strategy that's not subject to collective bargaining. And again, how these ideas of mandatory bargaining and bargaining of what strategy in the prerogative of management and what's the terms and conditions of employment and the prerogative of union contracts, basically as a legal question that hasn't been settled. So is the purchase or implementation of electronic health record a business strategy issue or a term and condition of employment? If it's business strategy, management can just buy whatever they want. If it's a term and condition of employment, they would have to negotiate over it. So we've written a bunch of these papers, and frankly, some of them people keep asking us to write these papers. Again, reflecting this idea of what's going on and how do we explain all this. And in this paper in JAMA, we called Restoring Physician Autonomy in the Area of Hospital Dominance. We said, hospital leaders are really financial stewards of the institution. That's their goal. And then physicians' goals are to be bound by medical ethics in the care of their patients. And those are really, those really conflict with each other. So we have seen a big growth in unionization, especially over the last couple of years. And we have some other work that's not published yet that looks at why. Why are doctors unionizing? And here's a headline from April about a strike, but really what the issue was staffing and quality concerns articulated by the docs. And when we've looked around at organizing efforts around the country, almost all the time, it's around these issues of staffing or quality rather than wages is the reason for the strike. Great. All right. Thanks, Nisha. Nisha, do you want to say anything before you jump off? Or did you leave already? So, one of the things that we need as physicians to think about, again, this idea of physician unions is really new to us. Are there models out there that we can consider of how unions have worked in a field like ours? We're clearly not assembly line workers. We're not Starbucks baristas. And so here are two very happy union members. So NBA Players Association, actually the professional athletes very generally are members of unions. And then if you go online, you could find this collective bargaining agreement that covers compensation and terms and conditions of employment for NBA stars. We've talked a little bit about to the NBA, we've talked a little bit to the NFL. And actually the different player unions are now getting together a little bit to try and understand their role as union leaders, both for sports and broader. But not all not all the provisions of the collective bargaining agreement relate to pay. Some of them relate to things like the conditions of work and the work experience. And the NFL Players Association union took a huge role in terms of concussion prevention, which was a workplace injury that employers were not caring, employers being the NFL owners didn't really care about. Here's another union member, happy union member, the Screen Actors Guild. So again, we're looking at professions that have very high wage, workers that have like really individual creative talents and high degrees of, scarce professional experience that all have joined unions. And then I've been interested actually also in the Airline Pilots Association. And, it's no secret that Southwest Airlines has had a huge amount of operational challenges. And you might remember the shutdown a couple of years ago. And then here's Southwest Pilots saying, look, we're not picketing because of pay. We're not picketing because of retirement. We're picketing because of the operational disaster that Southwest has become. Again, the terms and conditions of employment, that in fact they're not creating a safe environment for, airline pilots or the people that they transport. Our most recent work looked at something called a bargaining union, which is interesting. So we, as employees that want to join a union around a collective bargaining unit. And there are different ways in which these bargaining units have been organized so far, and we've got different representatives of different ways it's done. You can organize at a single hospital. You can organize at a single organization. So all the hospitals at Legacy Healthcare in Oregon organized together. So that was across hospitals. Anesthesia, so a single specialty at Cedars-Sinai and I guess Elmhurst. And then a mixed model. A line of healthcare was all the primary care workforce, primary care physicians, nurse practitioners, and PAs join their unions. But in that New England Journal piece that kind of described all this, we also recognize that in fact, if we have these single specialty unions or the single perspective unions, if physicians, it's not a group practice. It's still not the Kaiser governance models. And if physicians can't reconcile their interests within a single bargaining unit, we might find different physician unions can present conflicting agendas when negotiating with management. And we do see that like airline pilots and stewards may not be negotiating for the same set of things. The neurosurgeons and the anesthesiologists in the hospitals may not see the world the same way at the hospital either. In terms of governance, a new twist on all this. This is a paper that was Hayden just published last month, talking about private equity and labor law. And so under something called corporate practice of medicine law, you know, in lots of states, corporations can't buy physician practices. And so what happens is they set up different kinds of legal structures to acquire a practice. So they might put, a friendly physician model would be to say, Kevin, go out and set up a hospital medicine practice, and then we'll set up a management services organization to support you. We'll be the exclusive provider. And so technically the private equity firm doesn't own the practice. I own the practice. But in practice, they control the practice. And then if in fact that practice then contracts, say, with Stanford Hospital, the question for labor law is who's the employer? Is it Stanford Hospital? It's telling me how many hours a week to work. Is it Optum that might have bought my practice? Or is it Kevin Schulman's friendly physician practice that's my employer? And what might happen is if the courts determine that it's Kevin Schulman friendly physician, if you try and organize, Optum could just disband that practice. And so you would get no protections from the union. And so this is all brand new, and this is really an evolving area of law. So in that New England Journal piece, we said it's too early to assess whether this wave of physician unionization can counteract the monopolistic and corporate tendencies of hospital employers, and whether unions can help satisfy physicians' interest in governance and restore some degree of their professional autonomy that's been challenged under these new employment conditions. That's the work we've done to date. And as we said, I think this is a really open question that's going forward. If unions aren't the way we restore the governance of docs, then we have to think really hard about other structures to go forward, because what's occurring in the market isn't unionization, it's the governance challenges of acquired physicians and employed physicians. So let me stop there, and we've got people on the front lines, it sounds like, that are really facing these challenges. So it'd be great to hear from them.
Yeah, that was a great presentation, Dr. Schulman. I learned a few things, from your presentation. I'd like to add a couple points there. So, when I pursued my MBA, 10 years ago, there were not many physician leaders in hospital organizations. A lot of the CEOs of healthcare systems were non-physicians then. In the last 10 years, that has changed. There are a lot more physicians who are, CEOs and even COOs and even CFOs. However, my thought in those days was that once physicians get into these leadership positions, things are going to change, right? However, it did not happen. I think you touched on that point where, most leaders of these healthcare organizations are pretty much held accountable to the financial metrics of the institution, and hence, irrespective of your background, you still acted like somebody who's responsible for those financial metrics. That's one point. And then the second point is the way these big hospital healthcare systems, as they merge and buy out the small physician practices, is they monopolize, like you said, but they also affect the community, the people, negatively by reducing the choices they have of physician practices. Say if they're not happy with the healthcare system, and that may be the only system that employs a rheumatologist in the whole community. There may not be any other private rheumatologist. And when these huge health systems negotiate contracts with insurance companies, if the insurance companies do not reimburse at a certain rate, the hospital system can say, we don't want you. Then Humana, for example, in our region here, had that happen to them. Christiana said, we don't want to deal with you anymore. What does Humana do? Humana loses all those members. And where do those members go? They have less choice of insurance. They have to deal with the rest of the insurance companies. And if they end up agreeing to the rates that Christiana charges, then where does the insurance company get its money back from? From their members. So the insurance premiums for the members go up in return. So effectively, a lot of these healthcare systems that are not for profit that may be benefiting from a lot of subsidies from the state subsidizes a lot of these healthcare systems. However, they in turn negatively affect the same people that they intend to serve.
Yeah, I should say one, in terms of the hospital negotiating with the payer, again, the hospital's got two pockets. There's the facility fee pocket and the professional fee pocket. And so the hospital has the option of negotiating for itself in terms of higher facility fees and lower professional fees.
Yeah.
Damon, do you want to talk about your experience?
Yeah, I actually had a few slides which I can try to put up. Let me just try to share my screen here. Yeah, is that working?
Yes,
Yeah.
we can see.
All right, I won't take up much of your time. I really appreciated that talk, and I have shared Dr. Schulman's some of his articles, especially this New England Journal article, with a bunch of the WhatsApp groups of unionizing doctors that I'm in touch with around the country, and with my colleagues at Elmhurst Hospital. I'm Damien Archbold. Sam, thanks for inviting me, and Marvin. I'm really excited to see this intern program with PNHP, and I hope to make a connection between single payer and doctors unionizing. But there's a better webinar about that at the end of these slides, and I'd advise you to either Google it or take a QR code of that. So I'm an anesthesiologist at Elmhurst Hospital in Queens. Been there since 2019. As you heard, I have a pretty convoluted history. I'm American originally, but I did my medical school actually in New Zealand, and I finished my residency in New Zealand with a 3-year interlude in Ireland. And I also worked in Australia for 3 years as a flying doctor in Western Australia and locumed in small town Western Australia. And I spent a year as a fellow at the Hospital for Special Surgery on the Upper East Side, which is one extreme of the American health system, and then moved to the other extreme, which is Elmhurst Hospital, a public hospital, one of the 11 acute care New York City health and hospitals. It's the largest municipal health system in the United States, and it takes care of predominantly Medicaid or uninsured marginalized people, mostly immigrants. Most of my patients don't speak English. And so it's been a bit of a whirlwind, also working for MSF. Without any academic training or background like you all are engaged in health systems, I've kind of been at the coalface of a few of them. So I've developed some of my own thoughts, but that's led me towards the strong opinion that particularly doctors in the US need to get organized if they are going to have any chance of opposing some of the market forces that Dr. Schulman was describing. And so with this video here, the photo here is of the residents at Elmhurst Hospital who are members of Committee of Interns and Residents, SEIU, which is the largest resident union in the US. They went on strike in May 2023 for a variety of reasons. And as you can see on the sign there, they're pointing out that our hospital was completely inundated in 2020, in March 2020, and the residents were the tip of the spear in many ways. They were the ones who were watching these patients suffer and die, often unnecessarily because of understaffing, chronic understaffing, disinvestment in public health care. At one stage, we had 200 ventilated patients in our 500-bed hospital in Queens. We're situated kind of equidistant between LaGuardia and JFK and Queens. And it's a very densely populated area with mostly essential workers, people who deliver Uber Eats, and clean toilets and work 3 jobs often. Very hardworking people who suffered inordinately. And so these residents were people who bore witness to that, and I was too. And I think in many ways that radicalized them and many of my colleagues at the stark inequities in New York City and in American healthcare, but then the return to business as usual without much discussion of how can we reform the system led them and many of my colleagues to assess what power do we have. And doctors do have voice and power that's respected in society, but a stronger lever is the revenue that we generate, particularly the attending physicians. And Dr. Schulman, I think, mentioned that the spending on healthcare in the United States has risen precipitously to 20% of the GDP. So there's an enormous cost to the healthcare that we pay for, but the outcomes are considerably worse than the places that I've worked, like New Zealand and Australia. And it's complicated, but we're not getting a good deal. And that is magnified at safety net hospitals like Elmhurst. And so I think the residents felt that, and they got themselves organized very quickly and went on strike. And their main issue that they struck over was being paid differently from the Mount Sinai employed residents who were working across, who did the exact same job, but were employed by one of these nonprofit health systems. And they won their demands, and the patients were fine. This was a strike that was similar to an evening or a weekend. And I should say that in New Zealand, I was also a member of a union, the residents union in New Zealand. I strongly recommend looking up the New Zealand RDA. We had very good working conditions in New Zealand, and I'm surprised and dismayed at the working conditions of residents in the United States. This is just a bit more about what the hospital looked like that I worked in 2020. It completely collapsed from my point of view. And my team and I were the airway team responding to emergencies, intubating patients, putting them on ventilators, dealing with equipment, PPE, drug shortages, this is an article that I'd recommend you look up from Don Berwick. He also does a speech based on this article. But there is a lot of profit. There's a overwhelming number of administrators and managers. The payers, I mean, United Health Group is valued at $500 billion. And they are also the largest employer of doctors. And as Dr. Schulman said, that has been a marked change in the last 10 years. Now 70% of doctors are employed. And this enormous vertically integrated health insurance company is their largest employer. So the response to that is to get organized and use our labor power, which is considerable, given that all of the revenue generated in my hospital and in a hospital that employs doctors is passed through the fingertips of doctors. So when we sign our charts, that enables coding and billing. And like I've mentioned, I've worked in lots of different contexts, and I don't need to click on any electronic health record in order to safely do anesthesia and take care of my patients. So I think we all understand that doctors are held to higher professional standards, and we aim to do no harm, uphold medical ethics, and we see practices, the corporatization of medicine that is working against our patients and us, and the professional societies that were parts of the AMA and our specialty societies don't seem equipped, even in their vigorous advocacy efforts, to reverse the growing corporatization of medicine. So I think there's potential for organized doctors to have that leverage in the system to do that. And so we are trying to build power at our hospital and get more organized. We're part of the largest union of attending physicians in the United States, and UAPD is on the West Coast, and there's a lot. This is a moving target, changing very rapidly.